A very good morning to all of you, and I hope everybody is doing perfectly fine. Today, what we are going to discuss is a rare case where I'll be telling you how important it is to diagnose a breast lesion or breast carcinoma or any kind of pathology on time to prevent a significant morbidity or mortality in a patient. Fine. So this topic is basically for public awareness also, and being a doctor, we should be like diligent enough to diagnose, not to miss this rare entities. Fine. So whenever you examine a female patient with breast swelling, so please keep your mind open that this can be metastasized to different location. So एक तो important चीज है कि screening of breast malignancy is very important. So any breast mass or lesion which comes into your notice should not be taken lightly. A proper clinical, radiological and cytological or histopathological examination is very, very important so that we don't miss these lesions, these malignancy which can be life threatening to the female. And now what our case is about, it's about a case where a female presented with cutaneous metastasis from breast carcinoma. So let's discuss the history first. So see, cutaneous breast, जो breast metastasis होती है, so areas, it is common around the breast area, that is chest में, head and neck region में, with the involvement of the lymph node. It is common to find, fine. But these metastases going outside the chest wall, that is rare. So that we have to focus. So here what we are presenting, that it is a case of young female with bilateral breast swellings and with clinical radiological diagnosis of fibroadenoma. She was young female, and जहाँ पे हमने जब patient को FNAC के लिए भेजा गया, that is fine needle aspiration cytology, there we could prove or establish the diagnosis of bilateral breast carcinoma with distant metastasis. Fine. So see, breast carcinoma is very common to be found out in female, ठीक है? And cutaneous metastasis usually हमें नहीं दिखता है. We don't go for. We generally examine for lymph node metastasis. क्योंकि carcinoma है, तो lymphatic spread is more common as we all know. Fine. So cutaneous जो metastasis होती है breast carcinoma की usually कहाँ दिखेगी? Areas near to the primary tumor. Yeah, and in our case, this was I'm just giving you a brief history कि हमारा diagnosis क्या था. This was a triple negative bilateral invasive ductal carcinoma of breast with multiple distant metastasis on cutaneous areas, cutaneous skin areas like arm, trunk and thigh. See, a female, 36-year-old female, she presented with complaints of fever, fatigue, backache, swelling in right breast, था उसे for last 1 year. Fine, and she had been to so many places. कहीं radiology हुई है, कहीं FNA हुआ है. So she was not given proper treatment for last 1 year. उसके बाद last 2 to 3 weeks when she came to us in the surgical OPD, she came and then we got the FNA of that to be done for that female. तो हमने देखा कि last जो हमने history ली, the female she had multiple swelling in the left breast also. Right breast she was having for last 1 year. Left breast में last 2 to 3 weeks में multiple swelling which was noted by her. Okay, and she also complained that she's having multiple small cutaneous eruptions or lesions over different areas, जैसे कि trunk, arm, thigh for last 1 month. So swelling right breast, what she gave the history was initially choti thi, swelling 1 into 1 centimeter and progressively increased into to 8 by 10, giving a huge appearance to the breast mass. ठीक है, and these swellings जब आप हमने examine करा, these were irregular, firm, non-tender, with restricted mobility, with few lobulations. And this multiple swelling, this was about right. Now coming to the left swelling, जिसकी history उसने 3-4 weeks की दी थी कि उसको 3-4 weeks में बहुत सारे swellings develop हुए थे in the left breast, multiple small swellings ranging in size from 1 into 1 to 2.5 into 3 centimeters. So these swellings were multinodular, जो हम left breast की बात कर रहे हैं, firm, non-tender with restricted mobility. So what we got, right and left, currently right and left breast में she had multiple swellings. ठीक है, right तो it was a huge mass 8 to 10 centimeter. Left breast, rapidly progressive, multiple swelling she had, which was ranging from 1 into 1 to 2.5 into 3 centimeters. So both this breast masses had restricted mobility. However, in both the breasts, there was no retraction of the nipple, discharge नहीं था, कोई ulceration नहीं थी. Okay, and these swellings were not fixed to the underlying chest wall. So this is the way you completely examine a breast mass. Okay, you need to know the fixity to the upperlying skin. You need to know the fixity of the tumor to the underlying chest wall also. Fine. So these were not overlying skin से भी not जो mass थे वो free था और underlying chest से भी जो mass था वो free था. So see what we saw सर जो भी right and left breast की swellings थी बहुत ही huge हो गई थी और left वाला multiple rapidly progressive हो रहा था ये ठीक है over the last 1 month. General examination, after examining these both the breast, on general examination, a single right axillary lymph node was also noted and measured 1 into 1 centimeter. It was mobile and non-tender. And on examination, what she gave the history, I mean, multiple cutaneous lesions mile, right upper arm pe, right thigh, then anterior abdominal wall below the right breast. So these swellings were very small, 1 into 1, 0.8 into 0.8, and were firm to hard in consistency, nodular tha, flat nodule jaisa. Flat, you can say thickening of the skin with bluish discoloration of the overlying skin. So see, this case actually we have published in Indian Dermatology Online Journal. This paper is published. So see here you can see right breast में तो एक huge mass था 8 into 10 centimeter. I'll just show. ये था जो 8 into 10 centimeter mass था in right breast. Left breast में multiple swellings थे 1 into 1 to 2 into 2.5 to 3 centimeter के range में जो develop हो रहे थे within last 1 month. And see below the left breast you can see abdominal wall पे ही एक cutaneous eruption है bluish to red जैसा. And this was in the right upper thigh. This blue nodule, thickened flattening of the thick flat skin lesion was seen with bluish discoloration. This was seen. Fine. So ये pictures हैं left upper abdomen or right upper thigh. Okay. This was a very important case which we had done when I was there in Ramanaloya Hospital, Delhi. So after this examination of the general examination and the examination of the breast per se and different cutaneous swellings, radiological findings also we reviewed, and ultrasound which was done earlier. It showed large lobulated irregular mass in the right breast with multiple discrete nodule. Multiple heterogeneous nodules were noted in left breast. कुछ necrotic lymph node थे. A definite diagnosis of phylloid tumor. Impression. एक impression दिया गया था phylloid with a huge mass and considering the age of the patient also. And multiple fibroadenomas in left breast was suggested, and patient was this was a provisional diagnosis, and patient was advised for cytological and histopathological correlation. So her routine investigations were within normal limit. जो hematological parameters थे, routine biochemical investigations थे, those were within normal limit. However, her ESR, that is erythrocyte sedimentation rate, was found to be high at 51 millimeter at the end of first hour. So after we did the fine needle aspiration, then it was multiple prick FNA was done from different sites क्योंकि बहुत सारे nodules थे, so हमने multiple FNA करे थे from the large nodular bilateral breast swelling as well as right axillary lymph node. See, जब भी हम कोई metastasis establish करना चाहते हैं, we are supposed to have the primary lesion कि उसकी diagnosis भी वही हो ताकि हम उसको मेट से कोरिलेट कर सकते हैं. तो हमें साइटोलॉजिकली, हिस्टोलॉजिकली और इम्यूनोहिस्टोकेमिकल मार्कर वाइज भी we needed to establish the diagnosis that these both lesions are same, that these जो आपको यहाँ malignant cells मिल रहे हैं upper thigh में, abdomen में, ठीक है, right arm पे, so those are your mets from the parent lesion which is seen in breast. ठीक है, इसके लिए हमने पहले we worked up on the breast mass and the lymph node mass. उसमें जब हमने जीन्स और पैपेनिकुलर स्टेन करा फ्रॉम बायलेटरल ब्रेस्ट स्वेलिंग, इट रिवील हाई सेलुलैरिटी. मैलिग्नेंसी का फर्स्ट फीचर होता है कि सेलुलैरिटी इज वेरी हाई. ठीक है, डक्टल सेल्स मिले हमें, जो डक्टल ब्रेस्ट सेल्स होते हैं वो मॉडरेट टू मार्क्ड प्लियोमॉर्फिज्म के साथ, व्हिच इज आल्सो योर अनदर पॉइंट फॉर मैलिग्नेंसी. अरेंज्ड इन शीट्स, क्लस्टर्स, ग्रुप्स, ट्यूब्यूल फॉर्मेशंस हो रहे थे कहीं कहीं, एंड मेनी वर सिंगली स्कैटर्ड इन द बैकग्राउंड. ठीक है, सो ये थे राइट एंड लेफ्ट ब्रेस्ट मास से ये FNA किया हुआ है, यू कैन सी सिमिलैरिटी इज वेरी हाई, और यू आर गेटिंग मॉडरेट टू मार्क प्लियोमॉर्फिज्म, वेरिएशन इन द साइज एंड शेप को कहते हैं हम प्लियोमॉर्फिज्म, ठीक है। देखो कितने बड़े बड़े सेल्स आ रहे हैं यहाँ पे, एंड दोज आर विद हाइपरक्रोमेसिया है, लिम्फॉइड स्कैटर्ड है बैकग्राउंड में, देन यू सी एक बड़ा सा मास भी सेल भी है, जाइंट सेल्स, मल्टीन्यूक्लिएटेड जाइंट ट्यूमर्स, ट्यूमर जाइंट सेल्स यू कैन से। सो हाईली प्लियोमॉर्फिक था ये, कुछ कुछ सेल्स जो बीच बीच में आ रहे थे। सो मॉडरेट एनाइसोन्यूक्लियोसिस, कोर्स ग्रैनुलर क्रोमैटिन दिखा हमें, कुछ सेल्स में प्रोमिनेंट न्यूक्लियोलाई थे, इरेगुलर न्यूक्लियर मेम्ब्रेन थे। सो दीज ऑल आर योर cytological hint or this cytological probability towards a malignant lesion. Background में हमारे lymphocytes थे, cystic macrophages है, क्योंकि degeneration हो रही होगी, long standing swelling हो गया, one year से ज़्यादा था patient को, few stromal fragments है with adhered malignant cells. This image I will show it last. Stromal fragment, जो स्ट्रोमा होती है ना ब्रेस्ट, जब आप नॉर्मली फाइब्रोडिनोमा में होता है कि स्ट्रोमा भी प्रोलिफरेट कर रही होती है, ठीक है। तो स्ट्रोमल फ्रैगमेंट्स में अगर हम इन्फिल्ट्रेशन देखते हैं इन साइटोलॉजी स्मीयर, दैट इज आल्सो अ कैरेक्टरिस्टिक फॉर इन्वेजन ऑफ मैलिग्नेंसी, ठीक है। तो साइटोलॉजिकल फीचर्स के बेसिस पे हमने डायग्नोसिस दिया, बायलेटरल डक्टल कार्सिनोमा ऑफ ब्रेस्ट। सिमिलर द राइट जो एक्सिलरी लिम्फ नोड से भी हमने किया है FNA, इट शोड सिमिलर morphology or as was seen in the breast FNA, tumor deposits along with foci of necrosis. Now coming to FNA, now we need to establish that cutaneous swelling may be similar cells and malignant cells. So multiple cutaneous, subcutaneous swelling jo thi over the right thigh, anterior abdominal wall, right arm. We got on FNA what? Tumor deposits of malignant ductal epithelial cells as was seen in FNA from breast swelling. So see, this is the image from the thigh or abdominal wall swelling. कितना cellular है, variation in size and shape of the cells, ठीक है, बहुत बड़े cells भी हैं, छोटे cells भी हैं, and all the cells are showing your moderate to marked pleomorphism, high NC ratio, moderate to marked anisonucleosis, ठीक है, irregular nuclear membrane, hyperchromatic nuclei, coarse granular chromatin. So all these features are being noted here. This is the high power of the same. So you can see giant cells भी मिल रहे हैं, tumor cells. So what we did now, जब भी हम cytology करते हैं malignancy, see sometimes it is very frank, this is also frank, but histo is a definitive diagnosis to say, and for with histo only we could put marker. जो हमने क्या किया, cell block बनाया, जो हमने FNA material लिया था उसी का हमने, so it's a sort of histopathology जो आप देख सकते हो, क्योंकि आपको cell block में भी क्या होता है, वो एक morphological pattern हमें दिखा देता है कि histo में कैसा दिखता है, ठीक है। So we took biopsy also, true cut biopsy from the breast mass was also done, जो that showed invasive ductal carcinoma also. We put IHC on it also. फिर हमने जो cutaneous lesion से FNA किया था उसकी हमने biopsy नहीं करी, उसकी हमने cell block बना लिया उसके हमने, ठीक है। So FNA material which was for the cell block we procured it from the cutaneous swelling. So this smear, cell block smear ने भी show करा presence of invasive ductal carcinoma. And true cut biopsy, as I said you, bilateral breast से की गई, उसमें भी invasive ductal carcinoma, not otherwise specified with Nottingham grade 3. Ki67 was markedly high, 80 to 90%. IHC भी करी, that was negative for ER, PR, HER2 new, so that is more dismal. ठीक है, so all the three, these hormones ER, PR and HER2 new were negative. So it was a triple negative bilateral breast carcinoma which she was suffering from with multiple cutaneous metastasis. So ये सेल ब्लॉक मटेरियल है, इसमें भी आप देख सकते हो हाईली मैलिग्नेंट ट्यूमर, इसमें क्या होता है, हाई एनसी रेशियो है, हाई पावर पे आप देखो, हाई सेलुलैरिटी, मार्क्ड प्लियोमॉर्फिज्म, मार्क्ड एनाइसोन्यूक्लियोसिस, इरेगुलर न्यूक्लियर मेम्ब्रेन, हाइपरक्रोमैटिक न्यूक्लियाई, किसी किसी में प्रोमिनेंट न्यूक्लियोलाई भी दिख रहे हैं, एंड सेल ब्लॉक में भी एरियाज ऑफ नेक्रोसिस वर नोटेड, जायंट ट्यूमर फॉर्म्स वर सीन, ठीक है, and Ki67 was put on this, ERP or HER2 was also put on this, fine. So all was Ki67 was very high. It was 80 to 90% in both the cutaneous swellings as well as the breast mass swelling and the true cut biopsy from lymph node was also done. So all these three showed the similar findings. On histopath, IHC and cytologically we have seen here also. Ultrasound abdomen bhi kara gaya for the further workup, and for abdominal ultrasound pe it was found to have, she was found to have hepatosplenomegaly with multiple well-defined hypoechoic metastatic lesion in both spleen and liver, along with abdominal lymph nodes where also that was enlarged. 2D echo was normal, chest x-ray, skeletal survey kiya gaya, did not reveal any abnormality, but in view of disseminated presentation of bilateral breast carcinoma. Whole body CT or PET scan was planned to see any tumor deposits elsewhere in the body, but patient she refused and was referred for higher oncology center for further management. So see, to summarize this case, जो देखो ये A picture is your FNA smears from breast mass, ठीक है? High cellularity, I'm repeating the same thing. High cellularity है, बहुत ही malignant looking cells हैं with high marked pleomorphism, then variation in size and shape of the cells. Then B is also FNA from the breast mass. You can see ये background ये ना stromal fragment है ये, ठीक है? Stromal fragment में you are seeing all the periphery में देखो सारे tumor deposits हैं. So there is stromal invasion, invasive ductal carcinoma breast. We can give one cyto description also. तो ठीक है? C है FNA from the lymph node. यहाँ पे भी आप similar finding देख सकते हो, ठीक है? Then D is your FNA smears from the cutaneous swellings, ठीक है? Similar morphology. E is your cell block from cutaneous swelling, and F is your true-cut biopsy breast. So all this summarize that the lesion which she was having in breast had metastasized to various cutaneous location. In fact, in the meantime, we were reporting these histopath and the cell block images. The patient had complained of few eruption over scalp also. So it was very, very hardly, I think 15 to 20 days. In fact, when she was referred for high center and on follow-up, we found that she succumbed to her illness, and she within I think 15 days of this diagnosis. So see how terrible this malignant lesion can be. Okay, sometimes you don't get time. So coming to discussion, cutaneous mets, see it can be seen in various internal malignancy. हम देखते हैं cutaneous metastasis होता है, and sometimes see it can be an initial presentation of underlying malignancy. So similar case I had reported, just now I remember, एक पेशेंट था 28 साल का था, 28-year-old मेल, किडनी मास आया था उसका, मतलब नहीं, he had initially presented with the scalp swelling and submandibular कुछ था ये below the tongue, I think some mass was there, and he was referred from dentistry department for FNA. तो हमने उसका किया तो बहुत ही malignant looking cells थे, ठीक है? Scalp पे था and some eruption over I think in abdominal wall and the sublingual swelling. तो उसके बाद हमने जब ये करा उसका FNA किया, it was showing a very clear picture of papillary carcinoma जैसा होता है ना, तो ये papillary carcinoma जैसा. Now papillary carcinoma फिर हमने retrograde primary ढूंढने की कोशिश करी, तो that was found to have, then ultrasound जब उसका करवाया गया, he was found to have a big huge renal mass, ठीक है? And then nephrectomy was done of that patient, and that was found to have a papillary renal cell carcinoma, ठीक है? So see, sometimes, so that is a clue when you get a cutaneous FNA, cutaneous biopsy. So we need to be very watchful कि हमें कुछ ऐसा मिस नहीं करना है, कोई malignancy, और proper examine वो होना चाहिए, proper investigation should be done to find out the primary mass. नहीं तो आप cutaneous, फिर आप सिर्फ MET से आप वो नहीं, patient cannot go under any further treatment of METs जब तक कि अपनी primary established नहीं हो जाए. So that's why establishing a primary malignancy is very important, and which we can do with proper histopathological examination, IHC examination in conjunction with your radiological findings. Fine. So see, cutaneous हमें कहीं से भी मिल सकता है METs, कोई भी internal visceral malignancy हो तो initial presentation भी हो सकती है कि सिर्फ METs लेके आया patient, ठीक है? So overall cutaneous METs की जो frequency होती है, it is 0.7 to 10%. Variations है, in different studies you will say it. Most commonly जो metastasized to skin होते हैं वो कौन से होते हैं? Melanoma होता है, followed by breast carcinoma, nasal sinus tumors, laryngeal tumors, oral cavity malignancies. So this can present within few months to few years after the diagnosis of underlying malignancy, but concurrently भी हो सकता है, as was noted in our case, क्योंकि left breast में जब patient को mass develop होना शुरू हुआ, multiple mass, same time she started developing this cutaneous lesion over thigh, arm, abdomen, ठीक है? तो concurrent भी develop हो सकता है. So see, cutaneous mets from breast carcinoma is not so uncommon, हो सकता है, but distant metastasis is rarely noted. जैसा initially I told you कि ये head and neck region में ज़्यादा होता है या in close proximity to breast, जहाँ पे primary breast lesion है उसके आसपास होगा, but very few case reports are there involving the scalp, abdomen, upper extremities. But lower limbs में बहुत बहुत कम cases हैं जो हमने right upper thigh mass में भी हमने जो मेट्स देखे वो बहुत कम cases में reported है lower limbs में एक patient का literature it is reported in the in I think anterior leg, right leg, but it was noted on the right thigh. Okay. So in our case, see, extensive cutaneous involvement था distant side पे upper arm, right thigh, and thigh is very very rare site. Navratnam et al. He had reported a similar case of cutaneous lobular breast carcinoma, जो कि metastasized हुआ था anterior right leg, which I was talking about. And to best of our knowledge, we had done extensive literature search. No mets with two thigh was reported, and this index case of ours is being the first one. So see, clinically different patterns होते हैं cutaneous mets के जो breast carcinoma से arise हो रहे होते हैं. Nodular, telangiectatic, inflammatory, sclerotic, alopecia, zoster-form, papillovesicular, ulcerative, annular erythema, Page's disease. When patient goes to dermatology OPD, then this can be the gross जो image होता है, clinical picture the patient can present with. So nodule जो होता है, that is the most common presentation for breast carcinoma का metastasis, ठीक है? On skin, and zoster-form pattern जो होता है वो least common होता है. So triple negative in itself is a very highly malignant condition with dismal prognosis. So it represents your unique subgroup with a specific molecular profile. And this, as I said you, ER, PR, HER2/neu negative होता है ये, as the name suggests, triple negative. और present कैसे करता है patient? Mimic, you know, sometimes it can be small also, but large size tumor भी दिखते हैं. Grade 3 होगा with high Ki-67, the proliferating index बहुत ज़्यादा होता है. With pushing margins, the development of your recurrence भी ज़्यादा होते हैं, distant mets ज़्यादा होते हैं, and Nottingham prognostic index जो होता है वो भी poor होता है, and usually in the lower age group, the younger individual with BRCA1 mutation, BRCA1, and TNBC is also termed as a basal line. Okay. So histologically, TNBC, the triple negative breast cancer, can show you different morphology. Secretory cell carcinoma की तरह present कर सकता है, adenoid cystic, medullary carcinoma with prominent lymphocytic infiltrate, grade 3 invasive ductal carcinoma with no specific subtype. This was in our case. Okay. So size important नहीं है triple negative का, अगर small भी है, then also it has a tendency to metastasize to your viscera or brain. Okay, they have an aggressive pattern, and there is there is lack of effective therapies, and it has a very poor prognosis. ठीक है, 30% cases जो हैं वो respond करते हैं chemotherapy के. So standard treatment जो होता है इसका starts with chemo and radio, especially in cases with your widespread metastasis. So it varies from case to case what should be the proper line of management. Okay? So we'll not be going into the management part. So we'll be restricting to the diagnostic part. Fine. So there is a higher risk of early recurrence and dismal survival with mets. अगर concurrent metastasis was seen in our case, concurrent mets develop हुआ patient को, and she succumbed within 15 days of diagnosis. See, newer modalities हैं like anti-angiogenic drugs, mTOR inhibitors, EGFR inhibitor, and one EGFR inhibitor, that is cetuximab. It is being tried. It is being given to the patient. It's a chimeric monoclonal antibody which inhibits your epidermal growth factor receptors. Right? So that helps in treatment. So to conclude, so as I'll say it, see, breast cancer can be prevented in the initial stages to going into a highly malignant form, या फिर mets के साथ present करे patient. अगर हम early stage में हम diagnosis कर सकते हैं, that is a kind of a prevention you can say, कि अगर to prevent patient from going into a significant morbidity or mortality, so early diagnosis and early intervention. So that thing at least we can give to the patient. Fine. So cutaneous mets from breast carcinoma is common, not so uncommon. Fine. But distant mets outside the areas of chest and trunk, that is very rare. Like thigh deposit, which was seen in our case. In fact, scalp bhi tha, but we couldn't take the FNA from scalp. Metastatic cutaneous deposits may be initial presentation, concurrent presentation in even a clinically unsuspected case of triple negative breast carcinoma. क्योंकि size was not important, even small size भी हो सकती हैं TNBC की, जो metastasize भी कर सकता है. So see, FNA is very important. So FNA with cell block helps in prompt diagnosis. So histo takes a bit more time, 3 to 4 days लग सकते हैं, IHC भी लग सकता है time. But with FNA and cell block, you can give a prompt diagnosis. And proper immunohistochemistry helps in diagnosing or labeling it as a triple negative one. So different case has different approach, but in initial stage what we can do, screening of breast carcinoma if done on time, any breast mass if done on time can save many lives. Fine. So I hope this case you'll remember and you will bring into your practice whenever you see a patient, female patient with breast mass. Okay. Thank you so much. This case actually we have already published in Indian Dermatology Online Journal. It's a PubMed Index journal. See why it is important to establish such rare, publish such rare case, is so that we when we report or when we come into our clinical practice, we remember yes this case can be seen here. ये हमें जब हम ये FNA की slide या histopathy slides देख रहे हैं, then we can remember कि इस site में ये भी चीजें हो सकती हैं. So it is not new thing which we are, or it is a rare thing. New thing नहीं है, पहले भी हो चुका है, patient को हो सकता है. ठीक है. So hence a diligent approach is required whenever you see any cytology smears, histopath smear, or in fact when you examine a patient. So see, all these are integrated things. So it starts from the moment you come in contact with the patient. So your diagnosis should start from that point only. Fine. So keep these all differentials in your mind while evaluating your patient. Thank you so much for your patient hearing. Please like, subscribe and share my channel. Thank you so much.